All right, so we'll do each of them in turn. So our first question was focused on the role of the board, setting strategy, monitoring performance, shaping organisational culture, and sometimes that third one is the bit that gets missed off. So what did your conclusions on this?
So first I'll say that I have nothing to do with the NHS, so I think that's why I was selected as spokesperson for the table.
Respondent.
So the conclusion was that first priority is to understand what the patient needs and build from there, and it's actually much easier to get it right from the first time. So start by actually identifying the issues and then listening to staff, and then test it with the patient. Then create a common voice, setting the vision and the priorities for the organisation and also the behaviours, and work in partnership with all the stakeholders. And then the board needs to ensure that it happens and give the authority and direction to make sure.
I mean, you mentioned other stakeholders. I mean, are you thinking there that it's particularly in a hospital context, it's important not only to think about the hospital, but how those staff care for patients as they leave the hospital as well? Is that important?
Yes.
Was that part of the
It wasn't part of the discussion, but
I mean, what were you thinking about when you said it's important to work with all of the stakeholders? What makes a difference?
Basically the staff, and I think we mentioned also the clinicians.
Okay.
Anything else?
No, I mentioned the I mentioned the external stakeholders because on the other side of the fence you've got at the moment your primary care trust, but soon to be clinical commissioning groups, and you've got your general practitioners, and when the patient leaves the hospital environment you're going out into the community environment.
Yeah, so that's going to make a big difference if hospitals can be less insular in their health systems. What would others say? Has anybody got anything to add to that about the role of boards in shaping culture?
Can I just make one other point? We did have an interesting discussion about the size of boards and how boards function with a completely different size. And I don't think we heard any research about that. We had quite a lot of research today about boards, but does it matter if you're running an organisation with 10,000 people, or even a board for the whole of England, versus a board for a much smaller one where you're much closer to the patient?
And thoughts on that?
It's a different role, and the bit further up you are, the more you are reliant on other sources of information.
What other perspectives on this? Are there other things that boards ought to be doing that they may not be doing now, or good practice that you want to emphasise? Yeah.
I can't remember we've talked about it, but the leadership walkabouts we talked about on this table, and for the last few years a number of certainly acute trusts have been practising getting individual directors out in a pre-programme way, talking towards staff about what's going to go wrong on that ward, how a patient's going to be harmed, what can we do to try to stop that. So I think that, to me, reinforces that the board are concerned about patient safety as their number one priority, and there's some kind of visible face to who those directors are.
Absolutely. I think in our first seminar on regulation we heard from Andrew Spur from the Nuclear Regulatory Authority, and he was talking about spending about 25% of his time going out there and effectively validating or checking the information that he had coming to him on the board, which is an interesting perspective. Yeah.
Well, the Healthcare Commission did altogether about 16 investigations, and there were the threads that emerged from those investigations were actually very interesting, and two of them which were highly relevant to this discussion is, first of all, the importance of boards having as part of their, actually both setting strategy and monitoring performance, key information about how well their activities were doing, so that they could spot how things were going and intervene as and when they needed to. And the second issue that came out of a lot of that investigative work, and I think this is an issue which is true for any board, so it isn't just about the NHS, is how important it is that a board and its key staff act with each other and don't quarrel with each other. So what we saw was very often where things had gone wrong, there had been a breakdown between doctors, for example, and management, and that responsibility on leadership to ensure that in a complex world people actually act as a team, I think, is crucial.
Yes, Jocelyn.
Stephen Ramsden's talked a couple of times about authenticity in leadership, and one of the things that I would say from my experience is that in most hospitals people know perfectly well about the differences between clinical areas, wards, departments, and they know which are a problem. I think that lives alongside a rhetoric which is all about quality and safety sometimes, and it also lives alongside things like leadership walkarounds, and I think that disconnect between what's tolerated somehow and the rhetoric is very problematic, and I think that if boards would actually I've never been quite sure why it's like that either. You know, what's in it for people to tolerate bad practice? It certainly happens, and it's happened a lot in care of the elderly.
Is it a nervousness about tackling it and how to go about tackling poor performance?
Possibly, but I think if that was turned around, to send a message about a positive culture, one of the things is about tackling stuff that's going wrong very, very straightforwardly.
Thanks. Most of our non-executive directors have spent at least 1 or 2 half days in the PALS and Complaints department, actually shadowing the PALS managers, going out onto the wards and talking to the patients, and there was a significant difference in their attitude and approach to the quality of patient care after that, and the attention that they paid. Far more real interest rather than what might be perceived to be lip service prior to that.
And do the complaints come to your board? Do they see the complaints and discuss them?
Yes, they do, and we have a quality committee as well, that's a subcommittee of the board that looks at complaints, incidents, patient feedback, and correlates all that information together.
Mm-hmm.